Hello, this is Jacqueline Totterdale, Chief Executive at St George's Hospital in Tooting. You are listening to the HSJ Health Check podcast.
Hello and welcome to our new HSJ Health Check podcast. Each week we're going to gather a cast from our team of expert journalists to explain and debate the most important news issues right now in NHS policy and leadership. HSJ Health Check, to be published each Friday morning, will bring you a uniquely up-to-the-minute, robust and informed analysis. Our objective is to give you more insight into the often contentious issues and debates lying behind HSJ coverage, and to bring that coverage to a wider listening audience. We'll be available each Friday on the hsj.co.uk website and across all the main podcast channels. I'm Dave West, HSJ's Deputy Editor, and this week I'm joined by one of our core HSJ Health Check podcast team, Ben Clover, HSJ Bureau Chief for Efficiency and Performance, and also by Rebecca Thomas, our mental health correspondent. Each week we'll tackle 2 or 3 big questions from the week's news. And today, in our 30 minutes or so of podcasting, we're going to ask, firstly, why is there a care quality crisis in inpatient mental health and learning disabilities services? Secondly, do we need to redefine what success means for an NHS chief executive? And thirdly, what's the point of the new NHS legislation proposals? And firstly, Rebecca, we're going to start with inpatient mental health and LD. You've written a lot over the past year about emerging serious concerns about the quality of these services. And this week, that's been made official in a sense by the Care Quality Commission publishing its annual State of Care report, which has underlined the seriousness of some of these concerns and recorded substantial year-on-year increases in the proportion of these services rated inadequate or rated requires improvement. Clearly, it's a serious, hugely horrendous issue for the residents of these units and for their families. Often but not always, services commissioned by the NHS. How do you think we've got to this situation?
Difficult question to answer completely. I mean, the trickle of stories we've had over the last year or so. The CQC State of Care report wasn't an entirely massive surprise. We've had a trickle of really badly run services rated inadequate. It's hard to pin down. A lot of it perhaps seems to be around staffing, not just staffing levels. We know that's a big problem for everybody, but governance. How are these inpatient units ensuring that their staff have the right skills to deal with people with really complex conditions and a range of complex conditions, because we'll have units that don't just cater for people with complex personality disorder or complex psychosis.
They've all got to deal with a range of complex conditions. I'm always slightly suspicious when these things arise, and as you say, it's not a really great surprise. And suddenly there's a sort of an almost conspiracy among people and commentators of saying, "Oh, what a great surprise! There's such problems in these services, and we declare a crisis and hold a review." Is your sense that this is genuinely a new problem or something that's got a lot worse over the past 12 months or not?
Well, there's obviously the element of demand that is almost definitely going up. Whether we've got more demand in specifically people needing inpatient services, I don't think that's quite clarified yet. But honestly, this was if we're calling it a crisis now, it was a long time coming and perhaps just unnoticed before. I mean, mental health in the last 5 years has had an increasingly bigger spotlight. Yeah. That's not to say these poor units didn't occur 5 years ago. We know they did.
Yeah, it's often with these things, it's a combination of things getting a bit worse and a growing sense in society that it's not acceptable anymore, isn't it? I think.
But it does seem like a clear spate. Like over the past year or so, it seems like there's been like a story a week of like from the Care Quality Commission saying, we have put this place in special measure, we've rated this place inadequate, and it's almost always, it seems like a privately run facility. And we were talking about this outside. It's a surprisingly large amount of money the NHS spends on this, isn't it? It's kind of, you're saying like total mental health spend publicly funded in the NHS is about 12 billion.
Yes, around
that. And the privately run inpatient services are
1.8, I believe.
so it's a fair old chunk of NHS funding going into this market, which is run by kind of three private companies, largely, right? Kind of
Largely
Signet.
hold the market share.
Yeah, they've got so kind of Signet, Priory, and there's another one.
The Elysium.
Elysium, right? Oh, and kind of so yeah, it's interesting to debate whether kind of staffing issues affect everyone. Don't know. Kind of everyone has this problem, but there's been more focus on safe staffing across the NHS or NHS funded services, which these are. Recently, plus the ever growing demand, but there's fundamentally a lack of inpatient capacity in NHS services. Is that fair to say?
That comes down to it, and that's why, particularly in mental health, why we have the independent sector having such a big presence. I don't think that is. I mean, you'll know this better, but I don't think that's matched in acute services.
Oh no, there are much smaller proportions. So kind of, I think the private acute hospital turnover, so both doing NHS work and privately funded work, is about 5 billion. But that's compared to a sort of NHS kind of acute run sector of more like 45. So it's more like a tenth, whereas sort of the total NHS mental health inpatients. But I mean, is it fair to say that kind of private companies do the majority of inpatient care for NHS funded services?
I would say the super specialist stuff. So the secure units, for example, they have a huge presence in medium and low secure units.
There's something it's an interesting point someone made to me and Rebecca earlier this week, I think, or the end of last week, was about the fact that the private sector is also dominant in these services in the other UK nations, so nations which have been dominated by left wing or centre left governments for quite some time, and taken a generally very antithetical view to competition and private sector in the NHS. Still these sorts of services still completely dominated by the independent sector, without apparently too much of an eyelid being lifted.
And it's interesting why this came to be, and it might have been that as the devolved nations. So that's not what they're called, but I mean, so the nations with devolved health authorities, kind of Wales, Scotland, Northern Ireland, they probably were subject to the same health secretary back in the 60s who sort of moved. It's been a long-term trend over decades to try and get more care done in the community and less in inpatient units. So it used to be that most care, mental health care, which often wasn't that caring, was delivered in an inpatient setting. And it was actually Enoch Powell as a health secretary who said, we've got to move away from an attachment to kind of bricks and mortar and to do more care, and probably more compassionate care in the community. I don't know if anyone's ever done their PhD to actually track, all right, let's track it exactly which hospital got sold off at which point. But it wouldn't surprise me at all if most of these privately run units kind of operate out of facilities that the NHS used to run and sold off sometime in the 80s or 90s, or probably a lot of them are flats.
And do you think, we saw last week Simon Stevens of NHS England perhaps sort of getting the defence in early, but it suggested the NHS could get back into, it should be getting back and growing capacity in these kind of services. Do you think that's plausible, or it takes time to build these things anyway, does it? Is there a way around that?
Well, it takes time of course it takes time to build things, but presumably they've got the projections for growth required the same way that these big American-owned firms would have ideas of what sort of market they're going to see in the future. Because at the moment, it's just, I think, Rebecca, you were saying the other day, kind of even the private sector thinks it's going to run out of capacity fairly soon.
Yeah, I mean, at least twice in the last year, I've been told at some point, trust couldn't put a patient in a private sector bed because the private sector had run out of capacity. I found that very surprising.
Yeah, and then these people with a profit motive to do it. So it'd be interesting to see if they actually invest in the facilities. Traditionally, that's not what private firms operating in the NHS have enjoyed doing. But yeah, there is apparently more capital funding coming down the line. Maybe it would be an interesting use of that, instead of building something, instead of refurbishing some acute hospital roof somewhere, you actually kind of went, all right, we're going to have an NHS owned and operated and staffed at properly compliant levels inpatient unit, that the business case almost writes itself, really, because these are hugely expensive payments. Kind of like trusts like South London Maudsley would routinely spend like 10% of their budget or similar sums just on shipping people off to Cigna or Priory run places. I mean, I don't know if anyone's feeling particularly conspiracy minded, but it would almost make sense for if you kind of get the private sector's got all these assets, they're not being staffed properly, that's not allowed. Kind of if they continually got inspected and found to be inadequate to the point where services could be removed, or commissioners were going to go, well, we can't in good conscience send patients somewhere that has these safety concerns over and over, then eventually probably the private sector will have to exit some of those positions, and then I guess the NHS could buy them. But then, there's probably a court case in that.
There we go, the big Machiavellian plan to
repatriate
that's a
conspiracy
NHS services.
Theory. The CQC has been set on the hardworking private sector in order to realise cheaper.
That's what Simon Stevens was referring to.
Yeah, I'm sure that's what he said with his eyes.
We've solved it. So, Rebecca, on that note about the about NHS England, perhaps because of the way these services are regulated, or because of the nature of the providers, there has been in all this kind of coverage a lot of focus on failures in the provider sector. But it's clearly an issue for the buyers and planners of care as well, who are a sort of slightly complex mixture of NHS England, local NHS commissioners, local government commissioners. What do you think the role of commissioners is now? Now this sort of serious severity of this problem is being realised.
Well, perhaps it's an issue this new task force led by the Children's Commissioner can look into, and I would say probably should look into. But I question how, for example, scandals like Walton Hall get to the stage where they are a surprise. So there needs to be a question, fairly, over at what stage do commissioners become aware of the services they're paying for, and how often are they looking, particularly in, for example, private inpatient services. They're very expensive. So this is a big chunk of money commissioners are paying for.
But they're not as expensive, perhaps, as what the experience with the Transforming Care programme seems to be, that which the default response of commissioners or planners in this context is, well, these are terrible places, let's get people to live in a much happier way somewhere else. But the experience, you tell me, but the experience with Transforming Care, that seems to be that in too many cases it's actually so expensive or so difficult to bring that about that it's failed to happen in the way that the NHS.
Well, it's interesting with Transforming Care. I had a lot of conversations. There currently isn't the market for the community placements and the community houses we need, and perhaps that is a failure of Transforming Care. It didn't
market. You mean being providers who arrange that?
Yeah, providers who actually provide these housing placements, so that there currently isn't the market there to meet demand. So by default, people are staying within inpatient units, and we know from the numbers that.
Perhaps a question about how do they unlock and incentivise that the market or providers or whoever needs to be involved to actually provide those places and probably fund them properly.
Yeah, interesting. Somebody, a lawyer, said to me recently, the market will invest in those community places if it thinks it's profitable. So if you can't do these if you can't build these homes, for example, at scale, it's not profitable for them perhaps to invest in it. So where does NHS provision lie?
So kind of like the role of the
NHS?
Commissioner in kind of inpatient mental health and I guess to a lesser extent LD services sort of exposes the sort of myth that commissioning has become in some ways, in that you go, us as commissioners are buying services on behalf of the people of Luton or the people of England. And I've received disturbing information about one of the vendors that we have selected. So what do we do? Well, we have no choice but to send them to there anyway. We didn't want to send them to an expensive inpatient unit anyway. We had no choice.
There is no alternative.
So kind of the role of the market of commissioning there is, you could say, we're going to take a harder line on making sure places are staffed properly. Well, what does that mean? Kind of people exit the market? Maybe.
But they've been trying to reshape the nature of services by moving, many people out of those kind of services altogether. The CQCs, as I understand it, CQC's official line is these services should not exist. It is not the right way.
I was talking about mental health rather than LD services. Yeah, the LD services has been a sort of long running thing to try and move people.
All right. Well, it's some interesting ones to pick up in future there, I'm sure as well. And let's move on now to our second question for today, which is do we need to redefine what success means for NHS chief executives? And this relates to a point made in HSJ this week in a comment piece by Sarah J. Marsh of Birmingham Women's and Children's FT, arguing that a point about the reputation of NHS chief executives and NHS trusts and how this is judged. Sarah, as Jane, has argued that there needs to be a rethink of what's judged as success, and highlights her experience of a few years ago in Birmingham, taking on at a similar sort of time the coordination of children's and young people's mental health services for that area, and merging a trust at the time, the Children's Trust, with the Women's Trust, which had a number of serious problems, and that has, perhaps in the process, knocked the reputation of the Trust and herself. She argues that this needs to be rewarded in chief execs taking on these kind of difficult challenges, and it reflects an issue that we hear quite often these days about the need for chief execs to step out beyond their own organisation and help their system, help their neighbours, help other failing organisations in the way that perhaps was expected in days of yore in the NHS, before things were more market and organisation focused. We've also this week seen a second outstanding rating for Northumbria Foundation Trust, and I think we're expecting another one soon, where in an example where the chief exec of a successful trust has reached out and done something else. In the case of Jim Mackey from Northumbria, has actually gone to run the regulator for a NHS improvement for a couple of years or so, and in a sense have been rewarded for that in some way. But I mean, do you think there's a problem here, Ben, with chief execs being sort of unfairly marked down for doing these sorts of things?
I think it's always a really complex set of factors, like locally and nationally on it. I mean, I wanted to make the point, something Alistair picked up from one of his conversations with Hunt's, that Jeremy Hunt, when he was sort of redesigning the way the Care Quality Commission was going to work with trusts or work at trusts, he said he wanted to make more parallels with what Michael Gove had done with Ofsted, and he made the point that if you wanted to make your name for yourself as a head teacher in the education sector, you did that by approaching a real challenge, taking a real tough school and turning it round, not by sort of sitting pretty on a sort of a leafier place with good results. And he wanted a similar thing for the NHS, kind of trust leadership sector specifically. I think it's fair to say that hasn't entirely come to pass. It certainly hasn't left a strong residue that's survived him, because as much as you might want to encourage that, there's also pressure on leaders of organisations to deliver. So I mean, this is the same health secretary that quite publicly moved on to hospital chief executives because of problems with their A&E results, and these were both chief executives who'd very much moved to troubled patches. So when Libby McManus took over at North Middlesex, that was a place with serious problems and quite regular front page headlines in its A&E. Kind of East Kent had significant problems when Matthew Kershaw went there, and there's a sense that neither of them got quite the support they could have asked for. In fact, I spoke to people from a headhunting firm who said, "Oh yeah, those two sackings, those two movings on, basically killed the market for people willing to go and do kind of tough, not interim jobs, but kind of turnaround jobs."
Yeah,
because before, what's the point if I'm going to have the rug pulled.
It seems very case to case. I mean, if you're sort of one of the, it seems that some people seem to rise above it and do take on double difficult jobs, and they are rewarded with knighthoods, etc. And that's something that Jeremy Hunt raised, I think, about wanting to kind of dish out the honours for these kind of people.
Honour people, yeah.
Whereas there's kind of a sort of another tier where it goes very much unrewarded.
Well, I mean, it's difficult. I mean, I spoke to one trust chief executive before he was ennobled. Ennobled? I don't know if that's right. Before he was made, before he met the Queen, yeah. And I said, so as talk, you're going to take over a famously troubled organisation nearby you. And he said, I'm not taking over that organisation until an accountant I have paid tells me it'll work out. And he didn't.
And that's sort of the behaviour that, in a sense, Sarah Jane's trying to second guess, I suppose. Or, arguably, I mean, nothing wrong with doing the due diligence, but the case is actually you've got to kind of stick your neck out and take these risks.
I think you kind of sort of have to get the assurance before you stick your neck out, because he then got a locally famous good deal of long-running central support in order to take it over. And he's gone on to higher positions in London. But it's not all, for every case like King's taking over the Princess Royal and Bromley has, famously been quite bad for that trust, although it had problems anyway, and for the leadership there, there are other examples kind of it going well.
I would say, is there something about the article that I struggled with slightly, because I think it's a slightly...
we should say, but from the mental health point of view and West Midlands point of view, something about the example there.
Something, yes. I have a rough overview in my reporting. But so forward-thinking Birmingham, when it was launched, it was very troubled. And it's not a case of the trust having taken over an inadequate service. That service didn't exist before. So there are questions around, was due diligence done? There are still problems within the service that perhaps aren't
tackled. What happened? There was a sort of, do you know that detail? There was a sort of recommissioning and a repackaging of the children's and young people's mental health service.
Yeah, it was a new model of care essentially. That the basis was it went to 0 to 25. So we'll see a lot of other places that will be trying to do these services in the future. This was one of the first pilots of its kind, which we know had some very clear problems, was rated inadequate at the beginning. There are still some clear problems with the service. So I think that's a very different issue to, for example, I was talking when I did this interview with Paula Clark, who was former CEO of UH&M. UH&M is probably one of the toughest jobs.
North Midlands, yeah.
Yeah, sorry. Probably one of the toughest jobs in the sector, would you say, Ben? Yeah. And she said during that interview, from a regulator point of view, there isn't really you're treated tougher if you're taking over a basket case than if you're taken over a good trust.
Incredible how sometimes the goodwill can be so short-lived in those situations.
But the point is that's a very different situation from launching a new model of care and it not working out.
Yeah, indeed. Since I heard. Someone involved closely in setting up one of the new NHSEI regions, coming newly into these sort of regional jobs for the regulators, who kind of come in and said one of the things that struck them was there was no sort of pipeline management of leadership. Whether it be chairs or chief execs, there was sort of no idea of, well, we've got this real problem trust or even a successful trust who's in there's interims, or there's clearly going to be a change in leadership soon. Who might take that on? And what strikes me in some of these cases, and I think it has, in fairness, been recognised by some of the sort of people plan work, Dido Harding, the NHSI chair, doing about saying this has sort of been a kind of failure of basic, whether it's regional or national kind of line management, HR coordination of chief execs and senior management to actually put people in jobs that they can plausibly do, or put them in hard jobs if they can plausibly do it, put them in hard jobs and recognise, at least semi-formally, that it is a hard job, and you'll get, how long will you get, what are the kind of terms of expectation of turnaround here, rather than doing things on a substantially more ad hoc basis. That there's been one or two cases. I think it happened in Brighton not so long ago, where a chief exec was put in and lasted a very, very short space of time because it just didn't seem to have been thought through. But I mean, Ben, you touched on the sort of with the experience of that, the take of that senior acute trust chief about takeovers and stuff. You know, one of the results of this concern is that very little kind of M&A is actually going on, or has gone over the last year or so. Do you think that is a sort of a known problem? Where do you think we are on this what's been an issue over many years about what some people were thinking that we need to go down from 250 odd trusts to 100 or to 20 groups running the whole country? Where are we on that?
Well, it's a sort of vexed question of exactly what that would do. I mean, there's the view in some parts of the country that kind of we just need less boards. Boards are expensive. A board of a trust costs about £1 million a year. Kind of, we can do away with that, and we'll get rid of people who might obstruct some regional reconfiguration plan that you'd planned. In practice, that's probably just going to shift the problem somewhere else. It's kind of. Yeah, it's kind of like it's not like those people weren't doing a job. It's so instead of Trafford Hospital having its own board and its own medical director, it will just have its own hospital director,
MD, and medical consultants who will equally well have views about what should happen.
So the fundamentals might not change all that much. I mean, there are kind of important governance differences, like one of which I came across the other day. So when you merge a lot of CCGs. You do something quite different. You remove a kind of key barrier to using one specific bit of legislation. So when the failure regime got used in South London, the plan to close Lewisham A&E basically founded on this one legal point, which was that all the CCGs in the area had to agree with it. So all of the CCGs in South London, apart from Lewisham CCG, gave their assent, but then it couldn't go ahead essentially because Lewisham CCG wouldn't have it. Once you have all the CCGs merged, and you've got like on the committee of that one CCG in the region, one representative from Lewisham, one representative from all the other boroughs, right? Then they're just outvoted.
Yeah, you're pooling. You're
removing that level of accountability from a local, and that ability to say no to something from the local level, which I don't think has been properly understood.
Well, it's we're kind of moving on, and we will come on to talk about the sort of the legislation, which a lot of which pertains to that kind of regional governance, but coming on to change of structures on the commissioning side, as you do, and I think it has been slightly avoided. The genuine, often the real reason for bringing CCGs together is so that decisions can be made, which at the moment can't be made. There was one of the directors in Blackpool or in Lancashire, I think, made this perhaps slightly with slight regrets, but it made this clear in a piece in HSJ a month or so ago, and said, well, actually, look, there's just certain things we can't decide if we have to take it through every governing body.
So we're going to get a less detailed, less granular, less obstructive, potentially sort of system quite soon. Within the next year.
My question is could that just be removed by having a single governing body across the CCGs? I mean, do you need to merge them? If you've just got that single group of people that are...
If you've got a single body, you might as well merge them anyway, and then have to pay for less individual staff.
If the GP membership says yes, as they didn't in Staffordshire recently.
Yeah, indeed. Yeah, it's going to get. I think there was an NHS England committee on Tuesday. It seems commissioning committee looking at a whole raft of CCG merger proposals, and I think that they have knocked back again. What's out this morning? It looks like they've knocked back the Shropshire and Telford and Wrekin merger. Again, partly on probably a sort of bureaucratic basis of actually, can you really do this in time for next April? But possibly also a sort of, are you all really on the same page here? Is there consensus? So I think we're going to see a lot of that bubbling up. But let's move on sort of to talk about the third question that we had down for today, which relates to this issue of what is the point of the NHS legislation proposals which have been put forward in the Queen's speech on Monday, there was actually a kind of a complex and mixture of legislation proposals put forward by the current government as it is currently on Monday, which covered a bunch of stuff that we won't all try and talk about all of that here, but if we focus on the NHS legislation that's been put forward by NHS England and done lots of engagement, talked to the Health Committee and so on, have developed and consulted over the past year, have developed a range of ideas, changing various things. I think probably crucially split down into two things. One, a bit of stuff on the provider side and regulation about removing competition regulation and competition rules from which were substantially strengthened in the 2012 Health Act, binning a lot of that, the role of the Competition and Markets Authority, which we'll talk about in a sec. And on the other hand, on the other side, something more about this kind of system working and commissioning change, which is trying to make it easier for CCGs to work together and providers to work together with commissioners and people to delegate things back and forth so they can work in a sort of collaborative ways, and to allow, but on the face of it, not force foundation trusts to pool their decision making in that way, and to say actually we are 3 or 4 independent foundation trusts, but we cede our authority to a joint committee to make decisions of the kind that Ben might be talking about service change. But I thought I'd come to you, Ben, first because of this on the provider side of this stuff about the competition and mergers. One of the competition and mergers and the independence of foundation trusts, and one of the bones of contention so far about the legislation proposals has been the perceived threat to independence, perceived centralisation of authority with NHS England and NHS Improvement, and the specific one being that they now would under these proposals have slightly strengthened, in some people's views substantially strengthened powers to tell foundation trusts what they can or can't spend of their cash reserves. But there's a bunch of other stuff that people perceive as centralising. NHS providers has sort of ultimately has supported this stuff, but has found it difficult to get there, and has been in lots of negotiation and discussions about refining the proposals. Do you see these sort of centralising thing as an issue for trust chief execs, FT chief execs?
Again, it sort of depends on the chief execs, but sort of the tide went out on full autonomy a while ago, kind of for trusts. I mean, the idea that each trust was an island in sort of the Lansley paradise and would in fact activity its way out of trouble and would do innovative private stuff and all of that. Yeah, the tide went out on that idea like a little while ago. Sort of what it will come down to now is specific performance management things. So, I mean, at the moment, if NHS-IE really want to replace your leadership, then you have to be in special measures, and then they can appoint your chair. But in practice, there aren't the kind of the beasts that roamed the Serengeti of provider land kind of even 8 years ago aren't really there anymore.
You've got to see which way the wind's blowing, haven't you, when you're in these kind of jobs? And actually, if you're out there competing and trying to plough your own furrow, then you're perhaps not going to be
and who controls
successful.
Most of your income anyway? I mean, in a way, they don't have a choice about who they spend their money with in lots of cases. Question. But I mean, I don't want to understate it. Even I don't want to make too much of a point of difference for FTs, because it wasn't that long ago. In fact, we don't know yet how many, because NHS England's always too embarrassed to say how many arbitrations / expert determinations they did in 1819. But that was always a key example of how not great integration was going. It was when you have kind of the CCG and its provider having to take one another to internal court over 5 million quid's worth of invoices. Like that happened at Barking, and they lost. But the trust lost. And these are deeply ingrained systems. Like the current generation of provider leadership, that's the system they grew up under. That's the system they've always worked under. Is in lots of places it's more grown up than this, but in some places it hasn't been. It has been like, well, look, we've done all this work. You're gonna pay us for it. It's like, we didn't ask you to do all this work. We're gonna hire a team of coders to check that you haven't overbilled us. It's like, well, we're gonna hire a team of coders to say that we have. And like, it's stuff that the public rightly, understandably, only dimly understands. But if you do, this is probably why NHS England don't like to talk about it, because if you do have to explain to people that there's an internal market, a quasi-internal market in the NHS, and they go, what? And if you go, oh yeah, but don't worry, it's one that they take quite seriously, to the point where they can spend quite a lot of money arguing over money that isn't really real money anyway, but sort of internal NHS money, and it can get quite ugly. So it'd be interesting to see if there's any expert determinations / arbitrations last year and this year and in the future.
Is the internal market still rumbling on healthily, which actually we do see crop up in the news that we cover quite often, or actually is it genuinely disappearing?
Well, that would be a genuine test of how well all this integration, joint working stuff.
As I understand it, there's quite substantial regional variation. There's a lot been made of areas, trusts and commissioners moving off payment by results, per click of the turnstile tariff. But in actuality, there are some regions that have gone quite far down that road. There are some regions that have gone not very far down that road at all. And there are quite a lot of patches which try it for a year or two, realise it actually doesn't really work for either side, and they're perfectly happy to move back to the old way.
Yeah, and you've got to remember why the old way was introduced in the first place. I remember speaking to one of the people who helped design like the modern tariff system, and he said, well, I've got a block contract is just going, here's your budget, hospital, please cope with ever increasing demand of that. In practice, you'll fall behind, saying, "Oh, all right. Well, maybe we want to incentivise the trust to really gun down this waiting list." To use Jim Mackey's term.
On the competition thing, the removal of competition rules, which is linked, of course, to the internal market, but this legislation actually isn't going to come into force for quite a long time, if at all. It's really important to underline, as we speak on Thursday with Brexit negotiations hanging in the balance, which will also, of course, sort of just feed into the fate of this and the longevity of this government. So we can't really expect all this to happen. But chief execs, and I think this applies to mental health quite a lot, Rebecca. There are some trusts, some chief execs that are really fed up with tendering stuff. Being on the end of kind of tenders, particularly of community health services stuff. Public health is the other example. Although whether this legislation would affect that, I think is probably pretty uncertain. Do we think that people, trusts, incumbent providers are going to start to enjoy a reduced impact, reduced competitive tensions, from now, even without this legislation actually coming onto statute for at least 2 years or something like that?
There's already a kind of difficulty in no one likes to be seen to be suing the NHS. Like Virgin did it, and they got quite a lot of stick for it. Maybe they don't care, but they got. If I was their marketing person, I would care, and that's sort of a threat that's always been there. Is like, oh, how far are you actually going to push the legalities of these rules?
Yeah, I think we're starting to. I have a sense we're starting to see more contracts being rolled over, than they were before. Perhaps in anticipation of the actual rules being changed, but. On the other hand, Chief Exec's point of view, they're saying, well, the government and the NHS England have said this should not be happening. Why is it still happening to me?
Well, I mean, it can. Yeah, I mean, it might be a question, but by the time the legislation rolls through, might be a bit moot anyway. In that we're probably moving towards a situation like that for inpatient mental health services, where you go, we need the capacity, kind of, and it doesn't, I think a lot of the time when senior people are annoyed about a tendering process, it's not even that they're annoyed about losing the tender to Circle or something like that. It's they're annoyed about losing the tender to North East London Foundation Trust or something. And that has ended up with some odd situations. And also it's a lot of effort. It's a lot of money spent on lawyers. You can see why people are intrinsically against it. But the alternative is a system where just these decisions are taken.
And it's quite complicated.
And it's going to be in a world with fewer boards. There's going to be less scrutiny.
You're going to have to replace it with quite a complicated system to make any of the decisions for anyway.
Well, I mean, kind of, what sort of a new ICS will kind of go, all right, this one merged statutory body that also provides hospital services is going to provide all the community services as well. Maybe that makes sense. And also we're going to merge with the CCG. So, we're a de facto Scottish Health Board now. Like, well, what are the problems associated with that?
There are a few.
Right,
we've come to the end of our time. Thank you very much, Rebecca and Ben. And thank you to everybody for giving our first HSJ Health Check podcast a go. We will be here again next week, published on Friday, to download on hsj.co.uk and to access across all the major podcasting channels, such as Spotify, iTunes, SoundCloud, and the leading Android podcast apps. Send us any suggestions for topics, issues you'd like us to cover. You can find us on Twitter. My Twitter's at Dave W. West, or the email address you can find on the website or via my Twitter or whatever. Please spread the word widely and see you next week.